Welcome to The Explainer. Today, we're tackling a really big one, hypertrophic cardiomyopathy, or HCM for short. Now, if you're in medical training, you absolutely have to know this inside and out. Why? Because it's the most common genetic heart disease out there, and it's that classic, tragic reason we sometimes hear about young people dying suddenly on the athletic field. Okay, let's just jump right in with a classic scenario, one that should make your clinical alarms go off loud. Picture this. A young, totally healthy-looking athlete collapses during a game. They just faint. Now, sure, there are a few things that could be going on, but what's the one thing that has to shoot to the very top of your differential diagnosis? Yep, hypertrophic cardiomyopathy. All right, here's how we're going to break this down. First, we'll figure out what HCM actually is. Then, we'll dive into the nitty-gritty of what's going wrong in the heart. After that, we'll cover the workup for diagnosis and then get into the really important stuff, management and risk. And finally, we'll look at the bigger picture because this is all about genetics and family follow-up. Let's get to it. All right, first things first, the clinical puzzle. What is HCM? Let's nail down the definition of this thing. So here it is. HCM is an autosomal dominant genetic disorder. The key here is that the problem is in the heart's sarcomeric proteins, basically the little engines that make the heart muscle contract. This is really, really important. The thickening you see isn't because the heart is working hard against high blood pressure. No, this is a problem with the fundamental building blocks of the muscle itself, causing it to grow thick and stiff all on its own. And don't think for a second this is some rare zebra diagnosis. We're talking about 1 in 500 people. Think about that for a minute. That means you are absolutely going to encounter patients with HCM in your career. It's not a matter of if, but when. Okay, so we know the muscle gets thick, but how does that actually cause problems for a patient? Let's get into the pathophysiology, because if you get this part, everything else about HCM just clicks into place. It really all boils down to two main problems. First, you have diastolic dysfunction. That big, beefy ventricle gets so stiff it can't relax and fill up with blood properly. Think of it like trying to fill a balloon made of concrete. And second, and this is a big one, you get what's called dynamic LVOT obstruction. For a lot of patients, that thickened muscle actually gets in the way and physically blocks blood from being pumped out of the heart. Now, here's where it gets interesting. That outflow tract obstruction, it's not an all-or-nothing thing. Check this out. Only about 30% of patients have that blockage just sitting there at rest. Another 40%, a huge chunk, only get obstructed when they're provoked, when they exercise and their heart starts pumping hard. And then a full 30%, they never get a significant obstruction at all. So how does that obstruction actually happen? It's this beautiful, terrible little dance called the eject, obstruct, leak triad. And it happens with every single heartbeat. First, the ventricle ejects the blood with a ton of force. This creates a kind of venturi or suction effect that literally yanks the anterior mitral valve leaflet into the outflow path. That's the obstruct part. And of course, with that leaflet pulled out of place, the mitral valve can't close right, so it starts to leak. Eject, obstruct, leak. It's a vicious cycle. So when you understand that pathophysiology, the symptoms just make total sense, right? Patients get short of breath, dyspnea, and fatigued because the heart just isn't filling or pumping efficiently. They get palpitations from arrhythmias. They can faint, that's syncope, especially when they exercise because that obstruction gets way worse. But here's the kicker, and you can never forget this. Many patients are completely asymptomatic. They feel totally normal. All right, you've heard the story, you're suspicious, so how do we actually confirm the diagnosis? This is where we get into the workup, from your physical exam all the way to imaging. Listen, your physical exam skills are mission critical here. The murmur of HCM is famous for being dynamic. When you do a Valsalva maneuver, you decrease the blood returning to the heart, you decrease preload. This makes the ventricle smaller, and the obstruction gets worse, so the murmur gets louder. Now, have the patient squat. That increases preload, fills the ventricle, and pushes the walls apart. The obstruction gets better, and the murmur gets softer. This is the exact opposite of what you see in aortic stenosis. You have to know this for your exams. Up next, the ECG. And here's the thing. In HCM, the ECG is almost never normal. We're talking 75 to 95% of patients will have an abnormal tracing. You'll see classic signs of that thick ventricle, like increased QRS voltage. You'll see evidence that the left atrium is struggling. And you'll often see these really deep pathologic Q waves, especially in the inferior and lateral leads, that can look a lot like an old heart attack. Bottom line, a weird ECG in a young person should always make you pause and think. But at the end of the day, the gold standard, the test that seals the deal, is the echocardiogram. It's the one that lets us actually see the thickened heart muscle.
And the diagnostic number you need to burn into your brain is a left ventricular wall thickness of 15 millimeters or more in any segment, without another cause. Now, if the patient has a first-degree relative with HCM, that threshold drops a bit to 13 or 14 millimeters.
Okay, diagnosis confirmed. Now for the really important part. What do we do next? This is all about the plan, how we manage these patients and stratify their risk.
Now, this is probably the most serious conversation you'll have with an HCM patient. We have to figure out their risk of sudden cardiac death. And there are major risk factors we look for. Has the patient already had a cardiac arrest or sustained VTAC? That's a huge one. Do they have runs of non-sustained VTAC on their monitor? Is their heart wall massively thick? We're talking greater than 30 millimeters. Have they had unexplained fainting spells? And finally, is there a family history of sudden cardiac death from HCM? Finding any of these is a major red flag and starts the conversation about getting an ICD. So when it comes to treatment, we have two main paths. For medical therapy, the goal is to relieve symptoms. The first thing we reach for are non-vasodilating beta blockers. Why? Because they slow the heart down and make it contract a little less forcefully. This gives that stiff ventricle more time to fill, and it reduces that dynamic obstruction. If that doesn't work, we might try calcium channel blockers. But if symptoms are still severe and refractory, that's when we start thinking about invasive therapy, like a surgical myectomy where a surgeon literally shaves away some of that thickened muscle, or an alcohol septal ablation.
Okay, this slide is huge. High yield for exams, but more importantly for patient safety. There are some meds you absolutely must avoid in patients with obstructive HCM. The big ones are vasodilators like nitrates or PDE5 inhibitors. If you drop their blood pressure, you make the ventricle smaller and that outflow obstruction gets catastrophically worse. You also want to avoid digoxin in these folks if they have AFib, and be careful with your beta blockers. Avoid the ones with vasodilating properties like carvedilol or labetalol. Stick to the basics like metoprolol or atenolol.
And finally, let's talk about the bigger picture, because when you diagnose one person with HCM, your job isn't done. This is a family affair. And this is the protocol. It's a cascade of screening. Step 1, you take a detailed 3-generation family history. Step 2, you offer genetic testing to your patient, the index case. Now, if you find a specific mutation, that's great. It makes screening so much easier. You can just test all their first-degree relatives for that one gene. But if you don't find a mutation, or if testing isn't done, that doesn't mean everyone is off the hook. In that case, all first-degree relatives need regular clinical screening, with an ECG and an echo every few years for life.
So if you're going to remember just one thing about treating symptomatic HCM, let it be this. This is straight from the guidelines. For patients who have symptoms because of that left ventricular outflow tract obstruction, non-vasodilating beta blockers are your first-line therapy. Full stop. That is the cornerstone of how we treat these patients medically.
Which leaves us with this final, crucial question. You've just walked into the room, you've confirmed the diagnosis on the echo. What's the very first thing you should be asking them about their family? It's not just, does anyone else have heart trouble? It's this. Has anyone in your family ever died suddenly or unexpectedly when they were young? Because the answer to that question could literally save another person's life.